Let's talk a little bit about prevention of flares. And we'll raise the case of Juan, who's a boy, who comes in for continuing care of his atopic dermatitis. He was diagnosed with atopic dermatitis at 11 months of age, and basic measures give him good relief, the bathing, the moisturizers, controlling triggers, but he experiences frequent flares, and he just scratches tremendously when that happens, to the point that he develops secondary skin infection. So we should talk a little bit about how we might treat Juan and how we might modify his treatment plan.
Well, it's very important to do something to prevent Juan's flares. And we really would like to really reduce the number of flares overall, but also increase the time between each flare if possible. Of course, it's important to treat aggressively flares when they occur. But there are two approaches, that is reactive or proactive. Of course, we prefer the proactive approach, where once you recognize that Juan is having recurrent and multiple flares, you want to design a strategy to prevent these. So you really have two options in this type of a patient. You could use a topical corticosteroid 2 to 3 times per week. This would probably be a medium potency topical steroid, or a topical calcineurin inhibitor 2 to 3 times per week. Both have been shown to be effective on a long-term basis for preventing flares of atopic dermatitis.
Well, another key component to maintenance is the dilute bleach baths. And this is an antiseptic approach that, of course, doesn't increase the risk of resistance as opposed to using antibiotics more frequently. This is an approach that can be used whether children are infected or not. We'll often initiate this when the child comes in with an infection. We treat the active infection, but also initiate the dilute bleach baths. Now, the way that these are used is based on how large the tub is, because we want to get to a 0.005% strength. So in a standard tub, if it's filled, we're going to use a half a cup. And in a tubby, I ask the parents to measure it out, so how much water goes in, and we use a scant teaspoon. Technically, it's 3.8 cc's per gallon, or 1 cc per liter. When we know that that's how much water is used in the tubby. Even for specific hand or foot treatment, we can similarly create a solution and just have a quick 5-10 minute soak for that. The studies have suggested, though, that one can use this to continue to reduce not only the risk of infections, but very importantly, also the severity of the atopic dermatitis itself. When the studies were done, what was very interesting is that those were performed in a randomized double-blind manner in which one group used the dilute bleach and intranasal mupirocin ointment, and the other just used water in a bleach bottle and bland emollient up the nose. It was only those areas that were submerged that showed the reduction and sustained reduction in the severity of the atopic dermatitis, not the facial area, suggesting that it really is the bleach baths. And that's changed our management to make sure that we get the solution on a cloth to treat areas like the face and neck that otherwise might not get that exposure and extend that control. I should emphasize that in these treatments, we're not wiping out the bacteria. It may be reducing them, or it may not be doing anything in terms of if you were to culture, but really stresses then that it needs to be maintained, or that population will just come up again. In the trials that were done, it was twice weekly, and that looked very good. In my own personal experience, I find that for those who are more severely affected, daily dilute bleach baths are tolerated just fine and do a better job than the less frequent use of them. Also, in kids who are actively infected, sometimes sticking them in a bleach bath, even just a plain bath, can be very uncomfortable because of all the open, raw areas. So I'll often, if I'm using a systemic antibiotic, wait for 5 to 7 days into the course before I'll start that bleach bath and then continue the bleach bath. But it's really been an important part of our regimen.
And in terms of if we have to use a systemic antibiotic, the currently recommended agents would be a cephalosporin or amoxicillin clavulanate as drugs of choice for treating those obvious infections in patients with atopic dermatitis.
Yeah, fortunately, a small percentage of our patients have MRSA. We should emphasize that the only value of doing cultures in these patients is if you're trying to distinguish MRSA versus methicillin sensitive, because the majority, especially in lesional areas, are going to be colonized. So there's no value of finding staph, but rather what type of staph. And in those patients who have MRSA infection, then you may have to change based on the sensitivity. I should also mention that the dilute bleach baths are a little bit less effective as a single way to try to maintain in those with MRSA, and I often have to go to vigorous means to try to decolonize the entire family, as well as, for example, containers of emollients or even their topical products, which can grow out the methicillin-resistant staph. Well, when we're thinking about preventing and maintaining control, again, that requires some education of the patient and the family. We want to stress the need to adhere to therapy. It's so common as things get better for those families to say, oh, well, we don't have to use these anymore. But we need to stress that, of course, this is continuing treatment that is required, or else it will come back, or we need to be jumping in there rapidly with flares. Again, those written action plans, the multidisciplinary approach, and sometimes there are some other components that we need to stress. For example, those children who have secondary psychological issues can benefit greatly from seeing a counselor of sorts who can help to sort through that, introduce some behavioral therapy, even medication is needed. We know that there is an increased risk of attention deficit disorder in individuals who have atopic dermatitis, and recognizing that and getting that intervention can also be a two-way street. It can help as well with the atopic dermatitis. We have to be careful about food avoidance diets. There are some children, a small minority, who have foods that clearly are shown to trigger their atopic dermatitis. But I've seen too many families who decide to introduce their own very limited diets. We've had children come in even with kwashiorkor into the hospital because the parents have taken them off of things that give them protein, for example. And so we really need to be stressing that there needs to be physician-directed or nutritionist-directed guidance in order to manage any food avoidance diets. Controlling the trigger factors is very difficult. Of course, we can more globally talk, as you've so beautifully mentioned, of potential irritants or allergic triggers, and of course, the Staph aureus is a huge trigger, but beyond that, it's very hard to find just one or two factors that may be triggering that are easily avoided, as opposed to those children who have associated allergies where it then becomes much more important.
I see in adults often, if they have a job that involves wet work, that can be a particular problem in terms of aggravating their atopic dermatitis or any type of chronic eczematous dermatitis.
And I'll say that my most common example of that in children is hand dermatitis. It's not really their eczema per se, it's really more of an irritant dermatitis. But these kids with atopic dermatitis who in school are told to wash their hands and wash them very vigorously, we can change that by just pointing out that top of the hand dermatitis is from excessive hand washing, particularly in the colder weather with reduced humidity, and to send soapless cleansers, for example, to the school, or even just use soapless cleansers as a wash, and not even exposure to water, as well as the vigorous application of emollients and if needed, the topical corticosteroids to manage that.
Well, we've talked about WAN, and we've actually extensively discussed our treatment options. So what do we do for WAN? we really hit him hard with topical corticosteroids until his dermatitis has significantly improved. And then we really want to be proactive about preventing future acute flares by treating him with topical corticosteroids on a long-term basis. As we mentioned, perhaps 2 to 3 times per week, selecting medium potency topical corticosteroid. And then also incorporate the bleach baths. We can suggest perhaps 3 to 4 times a week that he take a bleach bath. And again, continue to educate both Juan and his family the importance of really complying with our recommendations, because the disease isn't going away, and you really have to stick to it.
Yeah, I'll mention one other piece about compliance, because I think it's just so interesting. There were studies done several years ago in which there was stealth monitoring by putting a sensor in the cap of the tubes of topical medication. And what the group found is that overall, over an 8-week period, there was 32% compliance.
Wow.
And that it went up in the 2 weeks right before the doctor visit, and it was also high in the 2 weeks after the doctor visit. So we need to recognize that this is the reality and really stress the need for compliance.
Very interesting.